My name is Reem.Ghandour and I'm a PGY-1 resident at Piedmont Columbus Regional Midtown. And today I'll be presenting on a pre- and post-implementation evaluation of a 90-minute Rituximab infusion protocol. My research team and I have nothing to disclose. The purpose of this study is to assess the risk of infusion-related reactions with the 90-minute Rituximab infusion protocol in patients with oncological malignancies at John B. Amos Cancer Center for second and subsequent infusions. Before I dive into the details of the study, I'd like to give you a brief overview of Rituximab. Rituximab is a monoclonal antibody that binds to the surface protein CD20 that is widely expressed on B cells. It has been in the market since 1997. It is on the World Health Organization or WHO list of essential medicines. Rituximab is commonly used in treatment of non-Hodgkin's lymphoma, chronic lymphocytic leukemia, rheumatoid arthritis, and idiopathic thrombocytic purpura or ITP. Rituximab can cause severe adverse events, including fatal infusion-related reactions. 80% of severe reactions typically occur during the first infusion, with time to onset of 30 to 120 minutes. An example of these reactions include urticaria, hypotension, angioedema, myocardial infarction, and anaphylactoid events. To minimize the likelihood and severity of infusion-related reactions, the United States Prescribing Information recommends pre-medicating patients with Tylenol and antihistamines and administering the drug at a slower rate. Our research took place at the John B. Amos Cancer Center, or JBAC. It is a comprehensive cancer center in Columbus, Georgia that serves 14 counties in the area. We have an estimated of 36 chemo outpatient infusion chairs with an average of 49 infusions per day and 25 Rituximab infusions per month. Before we discuss the objectives of the study, I wanted to define the infusion-related reactions according to the NCCN Common Terminology Criteria for Adverse Events. Grade 1 is defined as a mild transient reaction that does not require infusion interruption or an intervention to be provided to the patient. For example, fatigue. The second grade is grade 2, which is a minimal, local, or non-invasive intervention indicated in this case and for less than 24 hours. For example, hypertension, chills, or nausea. Grade 3 is a prolonged infusion-related reaction that is not rapidly responsive to symptomatic management with medication and it requires interruption of infusion. And this could be a bronchospasm, hypersensitivity, and abdominal pain. Grade 4 is considered a life-threatening consequences that requires urgent medical intervention to be provided to the patient. For example, acute respiratory distress syndrome and myocardial infarction. Grade 5 is defined as death. For cycle 1, Rituximab should be infused at a rate of 50 mg per hour. This rate can be increased by 50 mg per hour every 30 minutes to a maximum of 400 mg per hour in the absence of infusion-related reactions. If a reaction occurs, infusion can be slowed or stopped. From the diagram, you'll notice that the first infusion of Rituximab can typically take up to 5 or more hours, requiring up to 8 times rate manipulations by nursing staff. For subsequent therapy cycles, infusion is initiated at a standard rate of 100 mg per hour and titrated every 30 minutes by 100 mg per hour to a maximum rate of 400. This standard infusion can take a minimum of 2.5 hours to 4 hours, with 4 rate adjustment by nursing staff. Rituximab's long infusion time is inconvenient for patients as well as nursing staff. In the literature, there have been studies looking at rapid infusions of Rituximab over 90 minutes. A phase 3 multicenter trial investigated the impact of 90-minute Rituximab infusions on infusion-related reactions in patients with untreated diffuse large B-cell lymphoma or follicular lymphoma. They included patients with non-initial Rituximab infusion, no pre-existing cardiac conditions, circulating lymphocytic cells of less than 5,000, and no previous infusion-related reactions of grade 3 and 4. There were 362 patients who received 90-minute infusion successfully. Only 4 patients experienced grade 3 infusion-related reactions, and only 10 patients experienced grade 3 and 4. Yet, there was no fatal infusion-related reactions occur during the study. They concluded that 90-minute rituximab infusion is well tolerated and feasible for patients with diffuse large B-cell lymphoma or follicular lymphoma who tolerated the first standard rate infusion. Based on the results of previous study and other small trials, rituximab product labeling was amended in 2012 to include the FDA-approved option for a 90-minute infusion beginning at cycle 2 for appropriate patients with previously untreated diffuse large B-cell lymphoma or follicular lymphoma who meet the eligibility criteria. Based on important benefits with savings in both patients and nursing time and resource use, we created a pharmacist-driven protocol to convert eligible patients to the 90-minute protocol. It was approved as a physician's proceed order and went live on October 28th of the previous year. An educational session was provided to nursing and pharmacy staff at the Cancer Center. So let's take a look at our protocol. All rituximab 90-minute infusion doses will be provided in an IV piggyback with a total volume of 250 ml. It will only require one rate titration if tolerated as follows. The infusion will be started at 100 ml per hour, then titrated at 30 minutes to 200 ml per hour, and the infusion will be completed towards the end of the 90 minutes. Patients will need to be monitored and vital signs will need to be obtained at baseline, during the infusion, and 30 minutes after the infusion completion. If a patient develops an infusion-related reaction, the nurse will stop the infusion and follow JBAC infusion reaction protocol. The primary objective of our study was the percentage of patients who develop grade 3 or 4 infusion-related reactions with the conventional infusion compared to patients who received the 90-minute infusion. For secondary outcomes, we wanted to look at percentage of patients who develop grade 1 or 2 infusion-related reactions, mean rituximab infusion time, percentage of nurse adherence to infusion reaction protocol if a patient has a reaction. Our study was a single-centered, IRB-approved retrospective chart review conducted for outpatient rituximab infusions. It looked at all infusions received from January 1st of last year to March 1st of this year. We included all adult patients who received rituximab for an oncological indication with malignant lymphocytic cells of less than 5,000 and no pre-existing cardiac conditions. We excluded patients who did not have appropriate documentation and patients who had previous infusion-related reaction to rituximab or any other biologics. Looking at our demographics, we have 40% of our conventional group are male, while 50% of our 90-minute infusion group are male. The average age was 63% for the conventional group and 65% for the 90-minute infusion group. The most common diagnosis was similar in both groups. The most common one was non-Hodgkin's lymphoma, followed by diffuse large B-cell lymphoma, and finally chronic lymphocytic leukemia. For our results, we had 85 patients in the conventional group and 11 patients in the 90-minute infusion group. None of the group experienced grade 3 or 4 infusion-related reactions. However, there were 5 patients in the conventional group that experienced grade 1 and 2 infusion-related reactions. There were no reactions occurred in the 90-minute infusion group. The mean infusion time was 164 minutes in the conventional group compared to 91 minutes in the 90-minute infusion group. The percentage of nursing adherence to the reaction protocol was 80% in the conventional group. However, this is not applicable for the 90-minute infusion since none of the patients experienced infusion-related reaction. We had 11 patients who successfully received the 90-minute infusion with a total of 23 successful completed infusions. To conclude our study demonstrated no significant increase in incidence of grade 1 through grade 4 infusion-related reactions with the 90-minute infusion. Yet, there was 50% reduction in nursing rate titrations and pump manipulation. The 90-minute protocol reduced the infusion chair time by 72 minutes, or almost an hour. This is equivalent to 44% reduction in chair time without associated increase in infusion-related reaction. There were several limitations to our study. These include small sample size in the 90-minute infusion group due to recent protocol implementation. It was also a retrospective study design, and the study was not powered to show statistically significant difference between groups. Our center would benefit from a larger study looking at the infusion-related reactions in a larger number of patients, including non-oncological indications. Here is our self-assessment question. Which of the following benefits were observed with a 90-minute rituximab infusion? A. Decreased infusion time. B. Increased infusion chair turnover. C. Increased nursing workload. D. A and B. And the answer is A and B. And that concludes my presentation. Thank you for your time. Any questions can be emailed to me at Reem.Ghandour@Piedmont.org.